Good afternoon, everyone. I'm grateful to be able to share a pediatric perspective on pesticide exposures, which I hope will be of benefit to everyone attending today. This quotation from the American Academy of Pediatrics Council on Environmental Health summarizes what I'll be discussing with you today. Children encounter pesticides daily and have unique susceptibilities to their potential toxicity. Acute poisoning risks are clear, and the influences of low-level exposures on child health are of increasing concern. What are some of these unique susceptibilities? It's important to remember that children are not little adults. If you take a look at the infant in this picture, you can see that she is much closer to the ground, may or not be able to crawl, and so is not very mobile, loves to put things in her mouth, and has a great deal of skin in direct contact with the floor. Imagine this surface has recently been sprayed for insects, or the aerial drift of a pesticide from a nearby farm has landed on this floor, and you can appreciate risks that wouldn't affect an average adult. Add to this the fact that children breathe faster, eat and drink more per pound, and get a higher dose of pesticide relative to body weight than an adult would from the same exposure. Fetuses and children are actively and continually growing and developing. The brain and nervous system are forming and becoming more and more complex. The other organ systems in the body are forming and are not at fully developed levels. Any toxic exposure that interferes with any of this growth and development can have lasting and potentially irreversible effects. Newborns, infants, and toddlers also have a very large skin surface relative to body mass that increases the dose of skin-absorbed pesticides, which increases their potential toxicity. Detoxification of chemicals by the liver is also not fully developed during fetal life or in very early childhood. How do pesticides get into a child's body? An expectant mother and her unborn child share a circulation, so whatever the mother is exposed to, the fetus is also. As mentioned earlier, children breathe more rapidly, and whatever pesticide is in the air that they breathe can be absorbed, whether from aerial spraying or from house dust stirred by breezes or circulating air. Pesticides that remain as residues on treated food crops, or that have entered the water supply, or that remain in soil or in house dust where children may be playing, is readily ingested by mouth. Again, the relatively large skin surface of children increases the toxic dose from dermal absorption. A pesticide may cause acute toxicity, generally from a direct exposure to a pesticide application, or by accidental ingestion of a mislabeled container of a pesticide left within reach of a young child. A description of acute poisoning would fill a toxicology textbook and is beyond the scope of this brief presentation. We will spend a bit more time on the more insidious low-dose chronic exposures to pesticides, which are increasingly being detailed in recent research. It's also important to note that not all children are the same. Those with chronic illnesses like asthma or diabetes, those who have cancer or are receiving immunosuppressing cancer treatments, those who are developmentally disabled or neurologically impaired are all at increased risk, and many of these children have frequent contact with healthcare facilities and hospitals or other special needs facilities where pesticide applications may be occurring. An increased risk for a number of disorders has been found in association with pesticide exposures. Neurodevelopmental disorders have been linked to prenatal and early life organophosphate exposure, including chlorpyrifos. The risk of childhood cancers is increased with prenatal maternal exposure to herbicides and insecticides, and maternal and paternal occupational exposure prior to conception. Adverse birth outcomes have been associated with prenatal and parental pesticide exposure as well. Not all studies have separated out individual pesticides, so continuing research is needed to better define these issues. Another area of active research involves endocrine disrupting chemicals, which include pesticides that mimic the effects of estrogens or act as anti-androgens, and others that interfere with thyroid function. In addition to the metabolic effects of thyroid hormone, it is also critical to normal brain and neurological development in children. Another important point to keep in mind is that it's not just the pesticide that's being applied. Many other chemicals, sometimes labeled as inert, have their own toxic effects in addition to those of the pesticide, and there has been very little research on the effects of exposures to more than one pesticide. Questions that need to be answered include what effects combinations of different pesticides might have on both children and adults, and whether these various chemical mixtures increase each other's toxic effects. IPM minimizes the exposure of children and all of us to the toxic effects of pesticides and other harmful chemicals that may be mixed with them. I hope this information has been helpful. I will be happy to answer questions during the Q&A time. Thank you.
Thanks so much for watching our expert on IPM. I'm Sean Lynch, the director of the IPM and Healthcare Facilities Project at the Maryland Pesticide Education Network. We hope this has inspired you to consider new steps you can take to make your facility safer for your patients and staff. Please reach out to me at email at sean@mdpestnet.org if you have any questions regarding implementing IPM at your facility. To learn more, please visit the project at mdpestnet.org. Choose projects and then the IPM and Healthcare Facilities Project.